So far, we have discussed the causes of bleeding that included ITP, hemophilia, von Willebrand disease. Now, another cause of bleeding is disseminated intravascular coagulation. What is disseminated intravascular coagulation? Remember that normally under homeostatic conditions, coagulation and fibrinolysis are coupled. That whenever there is coagulation in the body, fibrinolytic system is also activated to prevent excessive coagulation. So normally, there is a homeostasis between fibrinolysis and coagulation. We have discussed that activation of coagulation cascade yields thrombin, and this thrombin then convert fibrinogen into fibrin, and this fibrin then stabilize the clot by deposition of the fibrin thread and its cross-linking. Now, when the clot is formed, then fibrinolytic system is activated in the form of plasminogen. Now, what happens in DIC? This balance is disturbed. There's a dysregulation of of coagulation and fibrinolysis. You can see in this diagram. Remember that the main culprit in DIC is tissue factor. There is clotting factor 3. Tissue factor or clotting factor 3, we discussed that whenever a tissue factor or clotting factor 3 is activated, it will activate factor 7, and then both of them will activate factor 10, and then a coagulation cascade will be started. So whenever there's a trauma to the blood vessels, now the causes of DIC, whenever there's trauma to the blood vessels, or whenever there's surgery, or during pregnancy, or even due to cancer, due to release of tumor necrosis factor, which exposes this tissue factor. So all these conditions which lead to the exposure of this tissue factor can cause DIC, that is disseminated intravascular coagulation. So the first step in the development of intravascular coagulation is exposure of the evil force that is behind DIC, that is tissue factor. So what will happen when tissue factor is exposed? Coagulation cascade will be started, and all the clotting factors and platelets, they will be consumed. So when the body will need clotting, nothing will be there. So due to this intravascular microthrombi, small thrombuses throughout the microvasculature. So whenever clot is formed, clotting factors and platelets and fibrinogen, clotting factors, platelets, and fibrinogen, all of them are consumed. So when the body need clotting, these factors and these platelets, they are not available. So you can say that the body develops consumption coagulopathy. Excessive consumption of the clotting factors and the platelets lead to the development of bleeding. This is known as disseminated intravascular coagulation. So what will happen in disseminated intravascular coagulation? Due to deficiency of clotting factors 8, 9, 1, 2, 3, 7, all the clotting factors are deficient. So due to deficiency of the clotting factors, PT will be prolonged, APTT will be prolonged. Due to deficiency of platelets, bleeding time will be prolonged. And due to consumption of platelets, platelet count will be low. Due to consumption of fibrinogen will be low. And due to excessive coagulation, breakdown product of clots such as D-dimer will also be raised. So raised PT, raised APTT, raised bleeding time, raised D dimer, decrease platelets, and decrease fibrinogen. Your diagnosis will be disseminated intravascular coagulation. Now let's discuss in detail what are the causes of disseminated intravascular coagulation. So regardless the triggering event of DAC, once initiated, the pathophysiology of DAC is similar in all conditions. So we have discussed that the main culprit in DAC is tissue factor. It is present on the surface of many cell types such as endothelial cells, macrophages, monocytes, and is not normally in contact with the general circulation. So whenever the tissue factor come in contact with the general circulation, so what things can cause this exposure of tissue factor to the general circulation? They include endotoxin can cause endotoxin that is released by the bacteria. So in sepsis, a DAC can occur. Tumor necrosis factor, it can also expose this tissue factor. So malignancy is another cause of DAC. So malignancy and endotoxin. Other than them, trauma and surgery and pregnancy. Remember these 5 causes of DAC. That is trauma, surgery, pregnancy, infection, and malignancy. They all can cause disseminated intravascular coagulation. What will be the presentation of disseminated intravascular coagulation? Bleeding at the venipuncture site. So whenever someone try to establish an IV line in patient with DAC, there will be bleeding at venipuncture site. Also, there will be ecchymosis or spontaneous bleeding at the site of minor trauma, bleeding from ear, nose, and throat, gastrointestinal tract, petechiae, and purpura. So this is the presentation of DAC, and the diagnosis will be confirmed on lab investigations. Lab investigation in all the things will be raised PT, APTT, bleeding time, D dimer, except 2 things that will be decreased. That is platelet count and fibrinogen. So thrombocytopenia and low fibrinogen. So just remember that everything is elevated except platelets and fibrinogen. The treatment of DAC is very simple. We'll treat the underlying cause. And if there is a severe bleed, then we can transfuse platelets, or even fresh frozen plasma can also be transfused. So platelet transfusion and fresh frozen plasma transfusion, this is a treatment for DAC along with treating the underlying condition, such as if the cause is infection, then we'll give antibiotics. So now some keynotes again. Warfarin is in warfarin toxicity or overdose.
Why the D dimer is increased?
D dimer, why the D dimers are increased?
Yes, please.
Okay, let me explain you this point. So normally there is a balance between coagulation and fibrinolysis. Whenever clot is formed in the body, fibrinolytic system is activated,
Right.
which result in the breakdown of the clot to prevent excessive clotting. Is that right? And
Yes.
D-dimer is a product of fibrinolysis. So when there is excessive coagulation, excessive clot formation in the body, this fibrinolytic system is also excessively activated. So this excessively activated fibrinolysis system will result in the breakdown of the clots as well. So that's why the product of the breakdown of the clots, that is D-dimer, they will also be increased.
Okay. That's fine. Thank you.
So some key points about Warfarin administration. Warfarin, we discussed that uh, warfarin will inhibit vitamin K dependent clotting factors, and vitamin K uh, dependent clotting factors such as 2, 7, 9, and 10. They are monitored through PT or INR. What is INR? International Normalized Ratio. INR is basically a ratio of the patient's PT to the ratio of the normal PT. So in warfarin administration, PT will be prolonged. All other APTT, bleeding time, platelet count, they will be normal because there is no problem with all these other things. Only vitamin K dependent clotting factors will be inhibited. Aspirin administration interferes with the platelet plug formation, so bleeding time will be prolonged. All other things will be normal. Heparin, again, just like warfarin, heparin will result in a prolonged APTT. So we can say that warfarin or the anticoagulants such as warfarin and heparin, they are monitored through activated partial thromboplastin time. Again, a comparison of von Willebrand disease, disseminated intravascular coagulation, hemophilia. In von Willebrand disease, two lab values will be raised.
You can hear me?
Yes.
Doctor, how aspirin works? Like, how aspirin works? I just want to know.
Aspirin is an antiplatelet drug. It inhibits the prostaglandin. All the NSAIDs and aspirin, they inhibits the prostaglandins, and there is one prostaglandin that is, I think, prostacyclin I, that is required for platelet aggregation.
Okay, doctor. Thank you.
So if there's no platelet aggregation, there's one more that is thromboxane A2, I guess. So both of them, they are required for platelet aggregation, and aspirin and other NSAIDs, they inhibit this formation of these prostaglandins, which are required for platelet. That's why they increases the chances of bleeding. And that's how antiplatelet drugs such as aspirin are used in the management of hypercoagulable states. So APTT and bleeding time prolonged. APTT means there's problem with the clotting factor 8 or 9, and bleeding time prolonged means there's problem with the platelet. So the diagnosis will be von Willebrand disease. If only APTT is prolonged, diagnosis will be hemophilia. If all three of them is prolonged along with D-dimer and decreased platelets and fibrinogen, then the diagnosis will be disseminated intravascular coagulation. So we discussed that DAC is a complication of pregnancy. There are some other complications of pregnancy, that is HELP syndrome and acute fatty liver of pregnancy. It's very easy to differentiate between HELP syndrome and acute fatty liver of pregnancy on the basis of lab investigation findings. In HELP syndrome, there will be low HB, elevated liver enzyme, and low platelet. In fatty liver of pregnancy, there will be a decreased glucose and plus minus increased ammonia, along with the elevated liver enzyme and low platelets. And in disseminated intravascular coagulation, everything will be high except two things, that is platelets and fibrinogen. So you can differentiate between these conditions in a pregnant woman on the basis of these lab investigation findings. So a pregnant woman in her 35-week pregnancy develops sudden severe abdominal pain and is taken for emergency C-section. Her HB is 101, WBC normal, platelet low, PT high, APTT high, fibrinogen low. So everything is high except fibrinogen, so it is disseminated intravascular coagulation. So this was all about some bleeding disorders. Now we will discuss bleeding due to some drugs such as warfarin can lead to bleeding, heparin can lead to bleeding, low molecular weight heparin can lead to bleeding. So we will discuss a short mechanism of these drugs and how to treat their toxicity one by one.